Pancreatitis is one of those diseases where everything can change within minutes. And as nurses or medical professionals, understanding each interconnected piece of the critical integrated map can mean a difference between stability and rapid deterioration. Let's walk through the entire framework in a way that shows you not just what happens, but why it matters clinically. To start with home care teaching, patients must understand that pancreatitis demands lifestyle change. Alcohol must be completely avoided. Dietary fat needs to be reduced. Hydration must be maintained. An early recognition of abdominal pain is essential. Patients recovering from pancreatitis who follow strict home care guidance dramatically reduce their risk of recurrence. This is why patient education becomes a continuation of hospital treatment rather than an afterthought. Moving to the nursing diagnosis, the core issues revolve around acute pain from pancreatic inflammation and autodigestion, fluid volume deficit due to third spacing, and risk for infection as necrotic tissue becomes a breeding ground. These diagnoses guide every priority intervention. A helpful mnemonic is PAFIR for pain, altered fluid volume, fear and anxiety, infection risk, and respiratory compromise. Respiratory problems arise because severe pain limits deep breathing, leading to atelectasis, which is easy to miss if nurses are not vigilant. Pancreatitis is defined as inflammation of the pancreas caused by premature activation of digestive enzymes that begin digesting the pancreas itself. Understanding its definition becomes more powerful when combined with demographical data. Pancreatitis is most common between ages 30 and 60, with alcohol-related cases predominating in males and gallstone-related cases more common in females. This demographic pattern should immediately alert clinicians during assessment. When taking history, you will often hear about alcohol use, gallstones, high-fat meals, hypertriglyceridemia, abdominal trauma, recent ERCP procedures, or certain medications. Special attention should be given to patients presenting after large meals or binge drinking, as these are classic triggers. Pathophysiology is where everything connects. It begins with obstruction or direct injury to the pancreatic ducts, leading to premature activation of enzymes, especially trypsin. Trypsin then activates other enzymes like elastase, lipase, and phospholipase. Elastase causes vessel destruction and hemorrhage. Lipase destroys fat tissue, causing necrosis and saponification, while phospholipase damages cell membranes. The pancreas begins digesting itself, releasing inflammatory mediators like cytokines, which then leak into the bloodstream and trigger systemic inflammatory response syndrome. A helpful mnemonic is TOA-C: trypsin activation, organ autodigestion, acute inflammation, systemic involvement. As inflammation spreads, fluid escapes into the abdominal cavity, causing third spacing and hypovolemia, leading to hypotension, tachycardia, and shock. Severe forms progress to necrotizing pancreatitis, pseudacis formation, abscess development, and even multi-organ failure. Medical management focuses on stabilizing the patient while giving the pancreas absolute rest. The patient is immediately made NPO. Aggressive IV fluids are initiated to counter third spacing, and electrolyte correction is performed. Pain relief is essential to prevent respiratory compromise. Nutritional support is considered early via enteral feeding to maintain gut integrity. Complications such as necrosis, sepsis, and renal failure require rapid escalation. In gallstone-induced pancreatitis, ERCP becomes both diagnostic and therapeutic. Surgical management is not always first line, but becomes necessary when drainage of pseudocysts, removal of gallstones, cholecystectomy, or debridement of necrotic tissue is needed. Rarely, extensive necrosis requires partial pancreatic resection. Nursing management is the backbone of pancreatitis care. Nurses must continuously monitor vital signs, fluid balance, urine output, pain levels, and lab trends. Pharmacological management includes opioids for pain, antiemetics for vomiting, antibiotics when infection is suspected, pancreatic enzyme replacements for chronic pancreatitis, and insulin for patients developing endocrine dysfunction. Non-pharmacological management includes positioning the patient in a lean-forward or side-lying position to reduce pressure on the inflamed pancreas, applying ice packs for discomfort, encouraging deep breathing to prevent respiratory complications, and reinforcing strict dietary modifications. Laboratory findings reveal elevated amylase and lipase, abnormal liver function tests, increased CRP, and possible electrolyte disturbances.